Hello everyone, I'm Dr. Anaga Joshi. I'm professor and head of unit in the Department of ENT at Siam Hospital and an ENT consultant at H&R Reliance Hospital and Joshi Clinic. So I'll be talking on imaging in otosclerosis. Otosclerosis typically presents with a bilateral representation with a female preponderance in the second and the fourth decades of life, and patient has a normal tympanic membrane with a bilateral conductive hearing loss and a type A tympanogram. So the diagnosis is pretty obvious, isn't it? So why do you need a CT scan? And when do you need a CT scan? When do you call for a CT scan? As for the indications, I would do a CT scan in all cases, but typically and always it's important to especially do a CT scan when the patient presents to you with mixed hearing loss, unilateral conductive hearing loss, or if the patient has vertigo or tinnitus. In all cases, revision stapedotomy. In all cases of pediatric cases, when you're doing a surgery when the patient is less than 20 years of age, and in all cases of doubt, when the diagnosis is a query. So, what is the role of imaging in otosclerosis? One is to confirm your diagnosis of otosclerosis, to look for any other cause of conductive hearing loss with a normal tympanic membrane, to look for any intraoperative challenges as like overhanging facial nerve or high jugular bulb or biscuit foot plate, predict any complications such as gusher. You can give a grading for otosclerosis, and in post-operative complications and in revision cases to know the position of the processes or if there's an associated ossicular necrosis or dislocation. What would you ask for? You would ask for MDCT with a 0.5 to 0.625 millimeter collimation, or a cone beam CT scan with a slice thickness of 0.08 to 0.125 millimeter. You ask for multiplanar deformated images in the axial, coronal, and stenwards and postural uh, uh, yeah, axis. So stenwards is typically where the axis is parallel to the petrous temporal bone. Here you can see the entire cochlea in this image, and a Poschel's view is perpendicular to the axis of the petrous bone, and you can see the entire semicircular canal in this type of imaging. You always ask for digital DICOM images so that you can view it on your computer and go step by step and look in all the planes. So let us study the role of CT imaging and otosclerosis. And the first one is to confirm the diagnosis of otosclerosis. You get otospongiosis, which presents as a hypodense lesion, typically at the fistula antifenestrum, as can be seen here. Rarely you may get retrofenestral otosclerosis, which is also associated with fenestral otosclerosis, and you get a pericochlear hypodense double ring lesion, also called as a fourth ring of Valvasori, and bilateral cochlear lesions are typically seen. You would also want to rule out any other causes of conductive hearing loss, like a third window, tympanosclerosis, ossification of these suspensory ligaments, or ossicular discontinuity or abnormality. So what is a third window? You can get a third window either because of the superior semicircular canal dehiscence, and basically the third window causes a pseudo-conductive hearing loss. Uh, so here you can see the normal uh, bony covering over the semicircular canal, whereas in the lower image you can see that there is a complete dehiscence of the bony covering of the superior semicircular canal, and it is typically you can get the entire semicircular canal on a Poschel's view. Rarely you may have a posterior canal dehiscence or a cochlear carotid fistula, which also may represent as a third window. When you do a stapedotomy in the presence of a third window, you will not get a hearing gain after surgery because the loss is a pseudo-conductive hearing loss. Sometimes otosclerosis and a third window may coexist, And Stapes surgery in this setting will unmask the symptoms of the latent superior submuscular dehiscence apart from not giving any hearing improvement to the patient after surgery. You can get calcification of the suspensory ligaments of typically which is seen in the coronal plane for the superior malleolar ligament, or in the axial plane you can get the calcification of the anterior malleolar ligament. Tympanosclerosis can be rarely diagnosed on a CT scan, but if it is seen on a CT scan, it is seen as ossified or calcified high density regions of soft tissue in the middle ear cavity, leading to a ovoid or linear or web-like forms. As you can see, that you can the tympanosclerosis involving the otic fixation of the malleus. And you can also get tympanosclerosis of the stapedial complex, which can give rise to thickening of the crura and the footplate, or diffuse obliteration of the oval window niche, or calcified stapedial tendon. Ossicular disruption or ossicular abnormality can also be detected on a CT scan, and which will give rise to conductive hearing loss. You can also look for any intraoperative challenges in the form of an overhanging facial nerve, persistent stapedial artery, a high jugular bulb, or a biscuit footplate. Facial nerve overhanging can be seen on a coronal scan. The red arrow in this case shows you the facial nerve and the oval window niche below that. So a lower hanging facial nerve may obliterate the oval window niche, and it has been reported that an oval window niche of less than 1.4 millimeter may give rise to a difficulty in approaching the stapes footplate during surgery. You can also measure the facial promontory angle, that is the angle subtended by the facial nerve and the superior wall of the promontory. And if it is less than 42 degrees, you can anticipate a difficulty during surgery. The thickness of the foot plate can be calculated, and it can be graded as grade 1 when it is 0.5 to 0.6 millimeter in thickness, grade 2 if it is 0.7 to less than 0.8 millimeter in thickness, and anything grade more than 0.8 millimeter can be said to be grade 3 or a biscuit footplate, or also it can be seen in obliterative otosclerosis. A high riding jugular bulb is seen in 10 to 15% of individuals, and it can be dehiscent in 0.5 to 1.7% patients. Although it may not give rise to any difficulty during stapes surgery, but there can be a brisk bleeding while you're lifting the annulus when you're raising the tympanomeatrial flap. The prevalence of the stapedial artery is seen in 0.02 to 0.48% patients. And in this case, on HRCT, you can see that the foramen spinosum is absent. So, and also the transverse facial canal can be seen to be widened. CT scan is important for prediction of complications like Gusher. You need to identify any cochlear malformation, enlarged vestibular aqueduct or cochlear aqueduct, enlarged internal meatus, or enlarged cochlear aperture. It is typically seen in excellent diseases, genetic diseases, where the stapes fixation is basically due to the inner ear hypertension. And that itself can give rise to the conductive hearing loss. The cochlear modulus is deficient, and the lateral portion of the internal auditory canal is bulbous. The labyrinthine segment of the facial nerve can be dilated. The posterior semicircular canal is also seen to be deformed. The vestibular aqueduct can be enlarged. And the outcome of stapes surgery in such patients is very poor, and you can get a sensorineural hearing loss, which is very frequent after such surgeries. Enlarged vestibular aqueduct can be termed as enlarged if the diameter is more than 1.5 millimeter at the midpoint, and this is by the Valvasori criteria. By the Cincinnati criteria, if it is more than 1 millimeter at the midpoint and more than 2 millimeter at the operculum. You also need to identify the cochlear aqueduct. Typically, the diameter is measured at the mid-otic segment, which is usually zero point 0.1 to zero point 0.2 millimeter in diameter. So anything more than 2 millimeter is 0.2 millimeter is abnormal. And you have to understand that the lateral orifice is the determining factor in occurrence of gusher more than the medial aperture. Any enlarged cochlear aperture or internal auditory meatus also can give rise to a gusher. So, a diameter of the cochlear aperture more than 3 millimeter or the diameter of the internal auditory meatus more than 8 millimeter is significant. Also, you have to see that whether there is any difference in the two sides. You can grade the otosclerosis as grade 1, which is just fenestral otosclerosis. Grade 2 A is where the otosclerosis is at the basal turn. Grade 2B is when it is at the apical and or middle turn, and C is around the lateral aspect of the middle and the basal, middle and the apical turns. Grade 3 is diffuse confluent cochlear otosclerosis with or without fenestral involvement. You can also do a CT scan to if you have any post-operative complications, such as the patient comes presents with vertigo or severe sensory neural progressive sensory neural hearing loss. You can see the CT scan was done in patient who had severe vertigo and regressive SNHL post the surgery, and can find that the piston projecting into the vestibule for more than 50% of the width of the vestibule, and also there is presence of the pneumal labyrinth. Also, you have to understand that the pneumal labyrinth is common within the first week after surgery, but anything beyond 1 week, you should suspect a perilymph fistula. In revision cases, you want to know the definitive etiology for the persistence of the conductive hearing loss. You want to do the surgical planning and know the placement of the processes or if there's any incus erosion or displacement. So to conclude, I would advise you to always do a scan before embarking on Stapes surgery. Mention your requirements and ask for DICOM images. Prepare a checklist so that you don't miss out on anything. Learn to read the scans yourself. Counsel the patient and consult the patient accordingly if you find any untoward findings on CT scan. Stapes surgery, according to me, is the most delicate surgery in our entire body. And preparation is the key to success and to prevent any complications. Thank you.